Hi, this is Dr. Jesalva. Welcome to my video regarding the Psychopharmacology Case Conference for Friday, May 20th, 2011. One of the questions which posed during this conference was the following. Which antidepressant medications have sexual dysfunction as a side effect, and what are some effective treatments for it? Some of the objectives for this video are the following. Be familiar with the psychopharmacology of sex and sexual dysfunction. Be aware which antidepressants have less sexual dysfunction as a side effect. And be familiar with some common treatment strategies in treating sexual dysfunction. First of all, you want to answer, how common is sexual dysfunction? Well, a recent study that looked at the prevalence of erectile dysfunction in the context of depression showed that there are varying degrees of erectile dysfunction depending on the severity of the depression. 25% with mild depression, 59% with moderate depression, and 90% with severe depression. As you can see, the prevalence of erectile dysfunction in this population increased with the severity of depression. What about the prevalence of erectile dysfunction with age? This study also found that there was a direct correlation with increasing age and the increasing incidence of erectile dysfunction. Basically, it's 39% for people age 40, 48% for age 50, 60%, 57% for age 60, and 67% for people who are age 70. Let's talk a little bit about the psychopharmacology of sex. The human sexual response contains three basic phases. The libido phase, which is the desire for sex and the sex drive. We talk about the arousal phase, which for men constitutes an erection, and for women, genital lubrication and swelling for women. And the final phase is the orgasm, which for men culminates in ejaculation. Let's talk about the neurotransmitters that are involved in these particular stages. For stage 1, desire phase, what I've outlined are the usual transmitters that are positive, which promote desire, positive effects for stage 1, and negative effects for stage 1, which is in red. As you can see, dopamine increases desire, estrogen and testosterone also increases desire, but some of the inhibitory neurotransmitters that reduce stage 1 desire are prolactin and serotonin. For stage 2, one of the things that's important that I want to highlight later is nitric oxide, which is a neurotransmitter that enhances arousal. Norepinephrine, dopamine, acetylcholine, melanocortin, and testosterone and estrogen also enhance arousal. Again, as an inhibitory effect on arousal is serotonin. Stage 3, again, we categorize this into norepinephrine as something that increases orgasm, serotonin, which reduces it, and nitric oxide and dopamine were sort of somewhere in the middle. Something to note here is that serotonin is both produces negative side effects on all three stages, whereas testosterone and estrogen, if on proper levels, increases the stage 1 and stage 2 phases of the human sexual response. Dopamine, again, exerts a positive effect on stage 1, 2, and a neutral effect on stage 3. And we will talk about this a little bit later on regarding Wellbutrin. Let's talk specifically more about nitric oxide and sexual arousal. This is the usual role of nitric oxide in sexual arousal. But I want to emphasize that this is nitric oxide, not nitrous oxide or laughing gas. Nitric oxide is a gas that is not your typical neurotransmitter. It's a chemical messenger in both the brain and the blood vessels, including those that control arousal. Okay? So let's look at this a little bit more closely. Nitric oxide is formed by the enzyme nitric oxide synthetase, which converts L-arginine into nitric oxide and L-sutralene. Nitric oxide then binds to the heme group of the enzyme guanylyl cyclase, which activates the enzyme, and this causes activation of cyclic GMP, which relaxes smooth muscle and other physiological functions. For men, this causes a relaxation of the vascular smooth muscles and causes an erection, and for women, the same mechanism causes swelling and lubrication of the vagina. However, with all good things, the body destroys the action of cyclic GMP by an enzyme called phosphodiesterase, thus ending sexual arousal. In the penis, this enzyme is called phosphodiesterase type 5, or PDE5. PDE5 inhibitors, like Viagra and Cialis and Levitra, inhibit this reaction, which causes cyclic GMP levels to remain elevated, thus allowing for sexual arousal. So the next question is, which antidepressants have sexual dysfunction? The short answer is that most of them have it to varying degrees. A recent study that showed the prevalence of sexual dysfunction among antidepressants showed that there is a substantial amount of sexual dysfunction in many of the antidepressants these days. A small study still, but a high prevalence of sexual dysfunction, as much as 70% with Celexa, and as little as 18% to Remeron, which I think was a little controversial because most of my patients who I've had on Remeron have very little or no sexual dysfunction reported with Remeron. So with this slide, the take-home point with this slide is that most of these antidepressants do have sexual dysfunction as a side effect. What about some of the SNRIs like Cymbalta? Well, a couple of studies looked at the prevalence of sexual dysfunction in Cymbalta, and the first study showed that the sexual dysfunction prevalence with Cymbalta and Paxil are very similar, 29% and 35%. Another study showed Cymbalta with about 47%, Paxil about 62.8%, which is very similar to each other. So the prevalence rate of sexual dysfunction with an SNRI like Cymbalta is very similar to some of the SSRIs. So what are some of the treatment options if most of these antidepressants have problems with sexual dysfunction? Well, one of the first things I do is just wait. Most of my patients who do have sexual dysfunction, and I would say a good majority of them, anywhere from 30 to 50%, have sexual dysfunction either dissipate or be reduced with just waiting, and waiting in terms of weeks to months. One of the ways you can reduce sexual dysfunction is to be able to lower the medication dosage. You run into problems with this because of some of the effectiveness of the medication may also be reduced. But this may be a good trade-off if the compliance rate is increased, if the sexual dysfunction rate, prevalence is reduced. Another treatment strategy is a drug holiday. One of the things that you could do, and this kind of reduces the spontaneity of sexual intercourse, is that, let's say if you're having sex on the 15th, what you might want to do is take your medication on the 14th, have sex on the 15th, and then take your medication after sexual intercourse on the 15th, as shown in this calendar. That way, if you have a medication that has a short half-life, it may be low enough of a dose that you may be able to bypass the side effect and still take the medication afterwards. We can also augment with other medications. Wellbutrin, being a dopamine inhibitor, as we showed a few previous slides before, have been related to an increase in the functioning of sexual arousal as well as desire, and sometimes with orgasm. As mentioned before, our PDE5 inhibitors like Viagra and Cialis and Levitra also are very good adjuncts to sexual dysfunction for both men and women. And finally, you want to check testosterone and estrogen levels to be able to make sure that they're within the normal limits. When you switching to another antidepressant is a little bit tricky because there are only a handful of medications that do not have that sexual dysfunction side effect. One of them is Wellbutrin. The other ones like Remeron, Leptra, and Pristiq, especially Pristiq with low dosages, do seem to have less of a sexual dysfunction compared to its other counterparts. However, you trade off some other problems with less effectiveness. With Wellbutrin, you trade off the anxiolytic effects. With Remeron, you trade off a problem with weight gain. With trazodone, sedation, and Pristiq so far, at least in my experience, has been effective in the low dosages, both at 50 and 100 milligrams to treat depression and anxiety. So it seems to be very promising, at least in my experience. To talk a little bit more about Wellbutrin, a recent study that compared Wellbutrin to placebo in a 12-week study showed that these two groups were statistically different after 12 weeks, showing that about 78% of patients in the Wellbutrin group reported a significant improvement in their sexual life compared to placebo. How about in women? Well, this recent study showed that sildenafil or Viagra has been helpful in improving the Clinical Global Impression Sexual Function Scale for women. It's one of the few studies that have used women have used Viagra in women and have actually showed an improvement in terms of their sexual functioning. Again, this has been statistically significant difference between placebo and the Viagra group. Secondary measures showed improvement in ability to reach orgasm as well. So this is just a little snippet of what we talked about last time. I hope you can make it to the next case conference. If you'd like to be included in my newsletter, please just email me at info@drjesalva.com. I'll be glad to have you in our mailing list. Hope to see you next time. Take care. Bye-bye.